So we have discussed about the bundle branch blocks. Now we'll start with the QT interval. The QT interval is measured in lead AVL. As this lead does not have a prominent U waves generally, diagram is scaled up because that means it is for seeing the waves carefully. We have zoomed it, and in AVL here, can you see the QT interval? QT interval is from the beginning of the Q wave to the end of the T waves. So this is the whole is the QT interval. And how many squares are there? There are about 1, 2, 3, 4, 5, 6, 7, 8, 9, about 9 squares. So 9 means 9 big squares. So 9 big squares means about 0.2 into 9, that is 1.8. So this is most likely a 50 millimeter speed. So we need to decrease the speed, reduce it to half, to 1.9. So it is very long QT interval can be seen here. Normal QT interval is about 0.44 seconds. So it includes the total duration of ventricular activation and recovery. When the interval is to be measured from a single lead, the lead in which the interval is the longest, most commonly lead AVL, V1, V2 or V3, and in which a prominent U wave is absent should be used. The normal range for QT interval is rate dependent. A commonly used formula was developed by Bassett in 1920. The result is a corrected QT interval or QTC defined in the following equation. QTC is equal to QT divided by root over of RR. The root over sign depicted wrongly. So QT interval, the upper normal limit be set as 450 millisecond, even 460 millisecond. The Bassett formula remains significantly affected by the heart rate, and that as many as 30% of normal ECGs would be diagnosed as having a prolonged QT interval when this formula is not used. So we need to correct this QT interval. The corrected QT interval is QT. Either you do this formula QT divided by root over of RR interval, or QT plus 1.75 into heart rate minus 60. So what is the significance of QT prolongation? Prolonged QT interval, they are the most common precursors of tachyarrhythmias like ventricular arrhythmias, and many drugs can cause prolonged QT interval. During COVID days, we know that many drugs like quinolones, like macrolide antibiotic, azithromycin we use, they can cause prolonged QT interval, and like many antidepressants and drugs like quinidine, propanamide, tricyclic antidepressants can cause prolonged QT interval. Myocardial injury, myocarditis, hypocalcemia, hypothermia, and hypertrophic obstructive cardiomyopathy, they all can cause prolonged QT, and that is the main reason, most of the cases, the reason of sudden tachyarrhythmias and deaths. So prolonged QTC, corrected QT, advanced AB block or a high degree AB block, and there are some syndromes, congenital syndrome, where they can also occur. Two of them should be remembered. One is Jarvel-Lange-Nielsen syndrome, and another is Romano-Ward syndrome. Now, shortened QT is shortened due to hypercalcemia. The most common cause is hypercalcemia or digitalis effect. We know drug digoxin digitalis. Digitalis uh, uh, effect or toxicity can cause shortened QT interval. Hyperthermia and vagal stimulation can cause shortened QT interval. Now come to the QRS axis. The QRS axis represents overall direction of the heart's electrical activity. Abnormalities hint at ventricular enlargement or conduction blocks. We call it hemiblocks. Like only if there is heart is in the ECG, we see the left axis deviation. It commonly occurs due to left anterior hemiblock. We will show what anterior hemiblock means. Now, QRS axis, if you see the normal QRS axis in the photo, we can jolly well see between
স্যার কিছু
minus.
শোনা যাচ্ছে না।
শোনা যাচ্ছে না?
হ্যাঁ স্যার শুনতে
হ্যালো,
শোনা যাচ্ছে। আমি
ও তাহলে তোমারটায় কোনো প্রবলেম হচ্ছে, তুমি আরেকবার বেরিয়ে
না
ঢুকে
স্যার
যাও।
ভলিউমটা একটু কমই আছে।
ভলিউমটা একটু কম আছে।
হ্যাঁ,
আমরা তো ক্লিয়ার শুনতে পাচ্ছি।
মানে আগের বার যা হচ্ছিল তার থেকে একটু কমে গেল।
আচ্ছা দেখছি, এই একবার এডকার করে ভলিউমটা 2 plus 9 and left axis deviation. If the axis looks beyond minus 30 towards the left side to minus 90 is left axis deviation, and right axis deviation from plus 90 to plus 180 degree. So how we can determine axis? The QRS axis, though there are two approaches, the quadrant approach, the equiphasic approach. The quadrant approach is very popular and it is very easy. Here what we see, predominantly positive, predominantly negative, or equiphasic. So here you can see the R waves are predominantly positive, so towards the y-axis, and this here the S waves are predominantly negative in the second picture, and equiphasic, the both waves are in the equiphasic. The both positive and negative diffraction size is almost same. So quadrant approach means if in lead 1 it is positive and in lead AVF it is negative, we call it left axis, and if it is lead 1 is negative and positive is AVF, we call it right axis. So here you can see the S wave, the mode is in the negative in lead 1, and in AVF it is more towards positive. So I told you, if in the lead 1 it is negative and AVF is positive, then it is right axis deviation, and in lead 1 if it is positive and AVF it is negative, it is left axis deviation. And if it is same in the both, it is normal axis. Lead 1 also positive, lead AVF is also positive, so it is normal axis. So you can see, you understand this. So in lead 1, if lead 1 is positive and AVF it is negative, so it is called left axis deviation. Positive and negative. So in lead 1 it is positive and AVF it is negative, it will be left axis deviation. Got my point? And if lead 1 it will be negative and left axis AVF it is positive, it is called right axis deviation. Now tell me, what is this? What is the, it is written here the same. Lead 1, it is more negative, and lead AVF, it is more positive. So it is right axis deviation. And lead 1, it is positive, and AVF is negative, it is left axis deviation. Now the equiphasic approach. Equiphasic means most equiphasic QRS complex you need to identify, and the identified lead lies 90° away from the lead. The QRS is the second lead in positive or negative. So we need to first identify in which lead it is equiphasic. So here you can see in which lead it is equiphasic. Both positive and negatives are same in lead 2. So if it is lead 2, if it is equiphasic in lead 2, then the axis lies 90° away from that lead. So lead 2 we know lead 2 has 60° angle. Lead 2 আমরা পড়েছি তো এই বাঁদিকে তলায় লেখা আছে, you can see lead 2 has 60° angle. So from 60 to 90°, so axis of this ECG will be -30. It is normal. Normal axis we know from -30 to +90. Now tell me what is the ECG, in which lead it is equiphasic? You can see in lead 1. In lead 1 it is equiphasic. So the axis will lie 90° from lead 1. Lead 1 is 0°, 90° from lead 1 is AVF. So axis is +90. Got my point? So two approaches we have discussed. One is equiphasic approach, and one is quadrant approach. Now tell me in which lead it is equiphasic. Here it is equiphasic in AVF. Can you see?
Yes, sir.
So if it is equiphasic in AVF, the axis will lie 90° from that AVF axis. So AVF axis is +90, so it will be at 0°. So 0° is normal axis. And if we count here the quadrant approach, if we apply quadrant approach here in lead 1 it is positive, in AVF it is also positive. So normal axis. In quadrant approach, what we have said in lead 1 and AVF, if both are in the same, say positive or negative, the axis is normal. In lead 1 it is positive and AVF it is negative, it is left axis deviation. In lead 1 it is negative and AVF it is positive, it is right axis deviation. Got it?
Yes, sir.
So in short, we can say axis. Very difficult. Don't try to understand. Just try to identify the axis by quadrant approach. And if it is positive or negative in both 1 and AVF, it is normal axis. If it is positive in 1 and negative in AVF, it is left axis. If it is negative in 1 and positive in AVF, it is right axis. Got my point? So we have discussed how to find out the axis, and with these two methods, we can identify all the axes quite easily. Quadrant approach and equiphasic approach. And equiphasic approach, what we have said, that axis lies 90° from the lead where it is equiphasic. Identified lead lies 90 degrees away from the axis of the heart. And here we need to remember this. One is 0 degree, two is plus 60, AVF is plus 90, and AVL is minus 30. Now, P wave abnormalities we have discussed. We have discussed about right atrial and left atrial enlargement. We will discuss about QRS complex. I told you QRS complex start from first negative deflection is the Q wave, and first positive deflection is the R wave, and second negative deflection is the S wave. So where different types of Q waves are seen. So if the Q wave is very small and just a deflection and it is not that much wide, we call it septal Q wave. Means it is occurring just because of the normal phenomena that while passing through the septum, there is one small Q wave can be seen. So to be significant, Q wave should be more than 25% of the R wave, or more than and more than 2 small square width. So if you see normal QRS complex in V1, there is slight prolongation of the QRS, and in V6 you can see just septal Q wave can be seen in V6. Small Q waves are seen. But in V1 there is no V wave actually. There is no Q wave actually. There is first positive deflection is R wave, and it looks like a opposite Q wave. So these are not abnormal Q waves. We will show what abnormal Q wave means. So this is a septal R wave, or this is a septal Q wave, which is less than 25% of the R wave. I told you to be significant, Q wave must be more than 25% of the R wave. So QRS complex, normal QRS patterns in the precordial leads follows an orderly progression from right to left. In leads V1 and V2, left ventricular free wall activation generates S waves following the initial R wave generated by the septal activation as RS pattern. As the exploding electrodes move laterally to the left, the R wave becomes more dominant and the S wave becomes smaller or is totally lost. In the leftmost list, left V1 leads V1, V5 and V6, the pattern also includes a septal Q waves to produce a QRS or QR pattern. Now, normal R wave progression. We can see the R waves normally progress from lower height to upper height. So we call normal progression of the R wave. That means if we go from V1 to V6, R waves height increases and S waves height decreases. You can jolly well appreciate from this. If you see V1, there is small R wave and more S wave, and if you go from V1 to V2 to V3 to V4, V5, V6, in V6 we have tall R waves and small S waves, or there is no S wave at all. So this is called normal progression of the R wave. But if the patient has COPD, patient has pleural or pericardial effusion, they can have abnormality of the progression of the R wave. So R wave will not progress. Or if the patient has ventricular wall abnormalities. Early and delayed transition. We can have transition of the R wave from V1 to V6 in the V3 or V4 or V6. So here in the topmost picture, we see transition occurring in the V2 and V3 phase. But in the lower picture, we are seeing transition occurring in the V6 itself, because in V6 in the lower picture, we have the same amplitude of R and S wave. So why this happens? This happens due to rotation of the heart, ventricular wall thickness, or there may be COPD changes or pericardial effusion. These can occur. These can affect this progression. So this is called early translation and late translation. So QRS complexes, non-pathological Q waves may present in 1, 3 AVL over V5, V6, and to be pathological, Q waves should be more than 2 millimeter deep and more than 1 millimeter wide, or more than 25% of the amplitude of the R wave. And what Q waves signify? Q waves signify damage to the myocardium. Q waves occur if there is already infarcted heart. And Q waves are very important. Pathological Q wave, if it is present, it signifies that already there is infarction has occurred in that area of the heart. So QRS in LVH and RVH, if you see the left ventricular hypertrophy and right ventricular hypertrophy, I have told you that left ventricle is looked, if we look at the precordial leads position, from V5, V6, the left ventricle can be seen. And from V1, right ventricle can be seen. So if there is problem in the left ventricular hypertrophy, we will have changes more in the V5, V6. So there will be more positive deflection in the V5, V6 in case of left ventricular hypertrophy. So in case of, you can see tall R waves in left ventricular hypertrophy, and you can see tall long S waves in left ventricular hypertrophy in V1. This is V1 and this is V6. So in left ventricular hypertrophy, what we will find? We will find tall R waves in V5, V6 and deep S waves in V1, V2. But my point? And what will happen in right ventricular hypertrophy? Right ventricular hypertrophy, the opposite picture will occur. There will be tall R wave in RVH, tall R wave in V1, V2, and significant S waves in V5, V6. So you can see the R wave, the heart V5 in V5, V6, the lateral wall or the left part of the heart is seen from V5, V6, and in V1, the right side of the heart is seen. So changes will be more in the right side. So what will happen? How we know that it is there is left ventricular hypertrophy? I told you in left ventricular hypertrophy there will be tall R wave in V5. So if you see here, if we calculate the V wave, amplitude of the V wave in V5, and if we add amplitude of the S in V1, if we add them, it will be more than 35. So this is Sokolow and Lyson criteria. S in V1 plus R in V5 or V6 more than 35. This is most important criteria. Sokolow and Lyson criteria. Another is an R wave of 11 millimeter or 1.1 millivolt or more in lead AVL is another sign of LVH. So another criteria is we have to look into the AVL, because I told you one and AVL also looked at the heart from the left side. But the Sokolow and Lyon criteria is more important. What will happen? There will be tall R wave in V5 and tall and deep S wave in V1. And if we add them, it will be more than 35. Can you add here? Here it is shown. This is R wave in V6 and this is S wave in V1. If we add them, here it is written, they have done it for us, that R in V6 in 26 and S in V1 is 22. So if we add them, it should be more than 35. If we add them, what will come? 22 plus 26, it is 48. So it is fulfilling the criteria of left ventricular hypertrophy. Got it? There are other criteria, other signs are also, because we can see there is T wave inversion here, but we have not discussed it now. But they also occur while there is left ventricular hypertrophy called strain pattern. Now, right ventricular hypertrophy, I told you just the opposite. What will happen? In right ventricular hypertrophy, there will be tall R wave in V1 and deep S wave in V5, V6. So to diagnose right ventricular hypertrophy, you can use the following criteria. One is right axis deviation, and in V1, R wave will be more than 7 millimeter tall. So you can see it is in AVF, it is positive, and in 1 it is more negative, so it is right axis deviation, and in V1 the R wave is more than 7 millimeter tall. So it is right ventricular hypertrophy. So right ventricular, in left ventricular hypertrophy, what is the most common cause of left ventricular hypertrophy?
Hypertension.
Hypertension. Very good. And what is the most common cause of right ventricular hypertrophy?
Pulmonary arterial hypertension.
Excellent. So there will
COPD.
be, and there will be scar pulmonary, which will develop, and there will be more pressure on the right side of the heart from the pulmonary circulation. Now come to the ST segment. ST segment is very important, and ST segment changes is the ST segment will denote ischemia or infarction of the part of the heart. It is very important because it is one of the criteria where you can diagnose acute myocardial infarction by ECG only, and you can thrombolize the patient at the earliest. ST elevation, myocardial infarction. So how ST segment looks? Variable shapes